soliciting them, nor saying that we're going to be considering them, but they need to be in my office by 9 o'clock if there is something like that floating around somewhere. Sign-up sheet up front. Who are we missing? Where's Penny? We've got people. His name? Pam Stevenson has resigned, and the Speaker has appointed Dr. Jackson to take her place. And I wonder where he is, because he said he was coming. Okay, we're going to wait about 5 more minutes, and since this is public input, we do not have to have a quorum, and we will get started. We have members that are on appropriations, and we will start. This is going out over the web. They will be able to pull it up and watch it. That's what we're missing. All right, you ready to start? You got the list? Got the list? Where is it? Okay, you got the list?
Oh, wait. Did you? No, it's back up there. Grab that top sheet, please.
Okay, we're going to limit everybody to 5 minutes. Welcome, Dr. Jackson. I've told people that you were joining our committee. The Speaker had just appointed you to the committee, so thank you very much for joining us. This is a public comment.
Just my name, but I know I don't have.
You don't have one yet, no. But we'll have you one for the next meeting. All right, let's go ahead and get started, and we will start off with the Senator, Senator Williams.
Chairwoman, Appreciate the opportunity to be here again today. I'm going to be on my best behavior since my wife is joining me in the crowd today.
Let's see. Can she stand up? Oh, welcome. We're glad to have you. It would have been better if you had two youngsters with you. Are they in Atlanta?
Most of the information we've gone over that I wanted to cover. I do want to say that I appreciate you and Representative Chanel and Representative Scott and Representative Keene, who's have joined us on trying to put together a compromise position on CON, as well as making some substantial changes in the CTCA portion of this bill. We feel like we've done a pretty good job at putting a compromise together, and I want to thank also Josh Belafani, who's worked very closely with us to make this happen. I think we got everybody involved in this process who's ever introduced a CON bill or worked on one to try to come together with like minds and develop a good bill. And I think we've done that. But when you have a 70-page bill, there are always minor things that come up that, and our intention is not to make wholesale changes in this bill. Otherwise, we find ourselves in the position we are in years gone by, not passing anything. But I wanted to just clear up a couple of things that I said that were erroneous yesterday, just because I thought they were in the bill and they weren't in the bill. And although we'll be giving those as amendments, I wanted the committee to understand what we intended to say and how we intend to change it in the law to make that right. So if I could let Josh just explain the couple of things that we need to fix in the bill.
That'll be fine. Josh, you're going to go to the pages in the bill? Or just
I can.
Okay, here, give me the bill. Has everybody got a copy their copy of the bill? Okay.
There are a couple changes at this point that I think effectuate the intent of the legislation, even if the language wasn't there. The first two deal with the destination cancer hospital provision. And if you go to page 28, on line 31, that subparagraph 3, is the commitment made by a destination cancer hospital to meet or exceed 3% of its annual adjusted gross revenue for uncompensated, indigent, and charity care. And I can get this to Betsy when we're done. The amendment would be after the word adjusted gross revenue, add and provide care to Medicaid beneficiaries.
Medicare too. And provide Medicare?
Provide care to Medicaid beneficiaries.
Okay.
The intent was for an indigent and charity commitment of 3% in addition to treating Medicaid patients.
Okay.
Representative Carter brought this issue up yesterday, and I was not sure how to, but we just wanted to clear it up, and that's the language that is.
It is.
Okay.
The second is on page 20. Line 24. But really you need to go to line 22 at the start of the sentence, such destination cancer hospital.
Okay.
And it would read, such destination cancer hospital shall not be required to apply or obtain additional certificate of need for new institutional health services, then adding, related to the treatment of cancer patients, then back to the current language, and such new institutional health services offered by the destination, new institutional health services, and then adding, related to the treatment of cancer patients offered by the destination of cancer hospital shall not be reviewed under any service-specific need methodology or rules except for those promulgated by the Department for Destination Cancer Hospitals. The intent here is, in those times when a destination cancer hospital is going to be treated as unique, as having the out-of-state patient base, that is limited to those times that they're treating cancer patients. Certainly in conversations we've had with CTCA, there's no intent of CTCA do open heart surgery for patients whatsoever. And so, but this kind of bootstraps that language and makes plain that whenever they're going under the Destination Cancer Hospital review criteria, it is only for those services related to cancer. In every other matter, they're going to be treated the same as existing hospitals that do not treat mostly out-of-state patients. There are, and this will be submitted to the committee as well, there's a couple more, and I'll just go briefly at page 19, line 25. This part of the bill is talking about the indigent, charity, and Medicaid commitments for existing facilities and when they're brought into the making the indigent charity commitments, as any new facility will going forward. The amendment will make plain that those providers who do not treat children will not be required to sign up for Peach Care. If they do treat children, then it's Medicaid and Peach Care. The way it would read on line 19, and this would be the same in the other places of the bill, provide care to Medicaid adding beneficiaries, and if the facility provides medical care and treatment to children, to Peach Care for kids beneficiaries, and provide uncompensated indigent and charity care in an amount equal to or greater than 2% of its adjusted gross revenue. And that change would be reflected whenever there is a provision talking about the requirement for indigent, charity, and Medicaid. And then there's an additional one but it deals with the definition of a continuing care retirement center. There's agreement between that community and the nursing homes. It would take me a little while to read it. Y'all can, with the committee's indulgence, I'll just submit it with everyone else. Yes, ma'am.
Things together. Thank you very much. Okay.
Thanks for
Senator Williams, is that all that you have? Okay. Senator Jackson.
No, ma'am. I'm a public servant representative. Jackson. Madam
Sorry.
Madam Chairman, I just have a couple of questions, if I may.
Certainly.
I'm fairly new here. Josh, and you introduced Josh. Josh, you represent who, sir?
I'm sorry. I'm the Deputy Executive Counsel to Governor Perdue.
Okay. Thank you very much. I have a question back on page 28, line 31. When we're talking about doing Medicaid, charity work, and indigent care, that 3%, does that include charity work and indigent care, which includes Medicaid, or is Medicaid separate?
Medicaid will be separate.
Okay. So the indigent care is 3% indigent care plus Medicaid.
That's correct.
Is there going to be a percentage of Medicaid patients? Is there going to be a limit on Medicaid patients or limit on Peach Care patients?
There is no provision in the proposed language that would put a requirement on how many Medicaid patients a destination cancer hospital would treat.
Thank you very much.
It'd be the same as in the current rule by DCH.
Thank you.
Okay. Thank you. And Josh is not serving in capacity, for your information, this time as the governor. He is who Senator Williams went to and the group that met to ask him to help us craft this bill.
Thank you.
Okay, that's all. There is a sign-up sheet. If anybody's come in late, they can sign the new part. Okay, going to limit people to 5 minutes. We will, run the clock on this. So our first person is Temple Sellers. Temple, if you will identify yourself and who you're with.
Madam Chair, members of the committee, my name is Temple Sellers, and I represent the Georgia Hospital Association. GHA is a large and diverse organization. We represent all of the acute care hospitals in the state of Georgia. Our membership includes for-profits, not-for-profits, rural, urban hospitals, public, private, and not surprisingly, with this level of diversity, we have some members that support certain provisions within this bill that others oppose. We do not have a consensus regarding the bill currently. We, of course, just received it yesterday and are continuing to try to get feedback from our members. And we have a board meeting next Tuesday where we certainly will be discussing the bill and getting some additional feedback, and of course we're calling members as well. Having said all that, what I can tell you is that GHA is committed and shares the desire of, I'm sure, the members of this committee as well as other legislators and other stakeholders to resolve the CON debate and move on to other pressing issues. A lot of the provisions in this bill were vetted last year in one form or another. We support a number of the provisions that are in this bill. A lot of them are consistent with the unanimous recommendations from the CON Commission. For example, all of the provisions related to streamlining the application process and the appeals process, eliminating non-clinical projects from CON review, and many others. The provisions in the bill that do raise some concerns relate to provisions that were not recommendations of the CON Commission. Some of them weren't presented to the CON Commission, so there was really no opportunity to discuss them and make a recommendation. An example of that would be the provisions related to cancer treatment centers and providing a special application process and exemption from review from certain service-specific requirements that apply to other hospitals. But a lot of the other issues that raised some concerns were vetted and discussed by the Commission, and these provisions just don't follow the unanimous recommendations of the Commission. And I want to just talk about a few of them very briefly. The first relates to indigent care and Medicaid. The CON Commission unanimously recommended that all exempt ambulatory surgery centers both provide Medicaid and or both treat Medicaid patients, agree to be a provider for Medicaid.
Can I stop you just for a second?
Certainly.
You are aware that over the years there have been hundreds of commissions formed, and that it is the prerogative of the legislature to take the recommendations of those commissions up for consideration, but we are not bound by law to follow them, and it is up to the legislature to make the hard decisions for that. Is that correct?
Certainly, Madam Chair.
Just wanted to get that clear as we went through this.
Absolutely. But again, you know, the unanimous recommendations of this commission were to require both Medicaid participation and indigent charity care, and that's consistent with what's required from CON regulated facilities, hospitals, and frankly CON regulated surgery centers. They agree as a condition of obtaining a CON to participate in Medicaid and to do a certain percentage of indigent charity care. It's normally 3%. This bill changes that recommendation in a number of ways. One related to new facilities going forward. It does give an option for facilities to opt out of participating in Medicaid in exchange for a slightly higher indigent charity care commitment, 4% instead of 2%. That is an option under this bill. We do appreciate the fact that the bill provides that whatever that commitment is for indigent charity care has to be met in the exempt facility. I think Josh mentioned yesterday, for those of you that were here, that was an area of contention we weren't able to reach agreement on, and this bill does recognize that is a facility commitment and needs to be satisfied by services provided in the facility, and we appreciate that. But nevertheless, the reality is that the bill would allow a facility to not participate in Medicaid, not treat Medicaid patients, and would still be able to satisfy the provisions of the bill. For existing facilities, there are about 250, I believe, exempt or ambulatory surgery centers in Georgia. Over 200 of them are exempt. This bill would allow them, if they chose, to basically maintain the status quo, to not have any indigent charity care commitment at all or any Medicaid participation. And the bottom line is our members are just concerned about a lack of required Medicaid participation in a time when it's becoming more difficult for a variety of reasons, many legitimate, to find specialists that are willing to treat Medicaid patients. One of the things that the bill also does, Madam Chair?
We're over time, but we're going to give you a little extra time since we have so few people. but you've used 5 minutes extra. Go ahead. Give you a couple
Okay.
more
Well,
minutes.
I'll wind up. I would. One of the other issues, just to bring to your attention, is the fact that the Commission did vote unanimously to maintain CON review for all multi-specialty ASCs, and this bill makes some variation to that because it allows certain physicians in different specialties to get together and still be eligible for the exemption. I think physiatrists that meet certain conditions are able to join, other specialties, and plastic surgeons that do hand. Now, our concern really is not with the specific exemptions there. The problem is the precedent that we're concerned it creates when you treat certain specialties differently than others. I'm sure you can appreciate the fact that hasn't really worked out very well for us. And we're concerned that other specialties are going to look at this and say, why shouldn't I be able to join a general surgeon with an orthopedic group? Why should I be prevented from joining with other specialties and having an exemption, and that we'll end up back in front of you again in the near future as we battle over that issue. And we'd like to avoid setting up future battles in whatever passes here. And finally, in conclusion, let me say that we very much look forward to working with you as we try to work through the process. We're committed to doing that. Many hospitals in Georgia are concerned that their current fragile financial condition might be worsened by some of the provisions in this bill. We just ask that you consider that as you debate this issue. And thank you very much for the opportunity to speak with you today.
Ms. Sellers, were you able to hit most of your high points and the major points you wanted?
Many of them, yes, ma'am.
Okay. Is there anything other burning one that you need to hit or anything like that?
Certainly not.
Because if there is, I want to give you a chance to.
I appreciate that, but
bring up the point now.
Thank you.
We have questions from the community. Austin.
Ms. Sellers, I appreciate your comments about wanting to resolve this issue. As you know, we've been on this for 4 years, I guess, since the CON Commission was started, and you gave us some specific examples of things you didn't like CTCA, and I appreciate that. But then you made an arbitrary statement at the end that the bill hurt the current fragile status of hospitals' financial positions, and I guess I would ask for you to tell me specifically how it does that.
Well, I think what I said, and what I certainly meant to say, was that there is fear among hospitals, many of which are really struggling right now financially, that certain provisions in this bill, and not just this bill, but frankly throughout the entire CON discussion, that there are certain expansions of exemptions to CON. There are some hospitals that are concerned about the general surgery exemption. There are hospitals that are concerned about expanding the threshold for exempt ASCs, increasing that to $2.5 million. There are many of those types of provisions that just ultimately result in more services being provided outside of the hospital setting that are profitable services as hospitals struggle to be able to meet the needs of many patients that just don't have the means of paying for those services.
Would you correct me if I'm wrong in this next statement? The requirement for physicians is Medicaid in a fixed 2 or a fixed 4. And if the ambulatory surgery center does not meet that Medicaid, Peach Care, and fixed 2 or the fixed 4, then they have to pay the money into the Indigent Care Trust Fund, which can then only be appropriated back to hospitals. Is that a fair statement?
I may not have understood the question. I
was just asking you to tell me if that was an accurate statement.
Well, if you're saying there's a requirement that they have to participate in Medicaid under this,
that's not what I said.
Okay, well, that I may have just misunderstood. The indigent charity care piece, if you don't meet that, it goes into the Indigent Care Trust Fund, which can only be accessed by hospitals. That is accurate.
Do all of your hospitals meet their Medicaid and 3% requirement?
I don't know the answer to that.
Thank you.
Certainly.
Thank you very much.
Thank you.
Any other questions? Right. Okay. Mr. Lewis.
Thank you, Madam Chairman. My name is Jimmy Lewis, and I represent Hometown Health. Hometown Health represents about 55 rural hospitals, and I rise today to speak in support of the bill that's presented. And with that, I'd like to share with you why, because we think it's extremely important to do that. We recognize, as did Ms. Sellers, that this is a very broad subject and a very divisive subject, and it's unfortunate that it is divisive, but it is. And at this stage of the game, with respect to rural hospitals, after much analysis of the overall industry, it's become abundantly clear that if we don't get past these kinds of issues and get to issues that are far more pressing and current in terms of immediate daily survival, we're going to lose a lot of hospitals. And the situation is that we've got 35 critical access hospitals, for example, that have lost or that have gotten out of the OB business. We only have 2 of 35 delivering babies. Most of them are trying to get out of the EMS business, and they're trying to shed costs wherever they can. When we're involved in the debate associated with the CON, it's consuming time and energy and dollars that we can't afford. So we get into the CON debate, and we looked at it, and we said, when it comes to CTCA, where are we on that issue? We ain't got a dog in the fight. There's a very good probability there won't be a CTCA built in rural Georgia. When we go to the discussion of ambulatory surgery centers, there can be some in some of the areas in rural Georgia, but it would appear that the language that's in the bill addresses the issues, particularly in the rural areas, that would be of concern there. And then the biggest issue is that of imaging, and we've had occasions where imaging had intervened in a rural community, and because that's pretty much pervasive across the board, one intervention can just about sink a hospital. And as we've talked with the authors and the people who have pulled this bill together, they have been most gracious in listening to the need of imaging, and as a result of that, we think the language is representative of the imaging certainly addresses the need that we've got. So as a result of that, when it comes to the bill and what it represents versus the need for rural hospitals, then we come to the conclusion that there is a need to differentiate, and it may be divisive, but there's a need to differentiate rural hospitals from the other subject, because the need of rural hospitals is cash. And we have not had an opportunity to have access to cash since the late 90s. There have been a couple of 3 instances, but the product of that is today that we, for the most part, have paid at 85.6% of cost. So when it comes to the decision, do we want to get involved in a policy issue that may not have any impact on us at all, or rather start to focus on the dollars and cents associated with surviving, we're far more about associating with the dollars and cents of survival. So it's with that I rise to you to make a very simple statement, that in the face of the cash situation and the dilemma and the continuing compressions that are coming down from the federal level, the rural hospitals are in desperate need to get out of the debate, to get over into the debate of cash and those things that will remedy their survival. And I'll end by saying that I just finished a 2-day trip through South Georgia, 4 hospitals. Of the 4 hospitals that I visited, 3 of them today are in a struggle to make payroll. The 4th one would be, except they had a relocation of a physician into the community that brought some volume with it. Were it not for that, it would have been 4 for 4. So we implore you as a committee, we thank you for looking into this, and certainly support this movement in this bill.
Okay. Are there questions for Mr. Lewis? Okay. And in looking at the bill, Mr. Lewis, you feel like we've protected our rural hospitals? Okay. Thank you for your testimony. Lisa Joyner.
Thank you, Madam Chair and committee members. I'm representing the Georgia Society of Ophthalmology and the Georgia Society of Ambulatory Surgery Centers. I'm sorry Dr. Goddard wasn't able to stay for the hearing this afternoon since it was postponed. He's an ophthalmologist in Carrollton who actually owns the first LNR center granted in Georgia, and he's been a great resource. Well, after about 3 years of this, we never thought we would see a bill we could support, but we certainly appreciate all the work that's gone into this. We have no serious problems with any of it, and we hope there'll be a peaceful resolution to this through this piece of legislation. Thank you.
Again, Ms. Joyner. Seems like to me, I thought that I'd heard on several occasions that it was your groups that were the biggest people in opposition to this bill. Could I hear that a little
louder? Not today, and not for some time. Well, all of our issues really have been addressed. There are always little tweaks, but we certainly don't want to do anything to be disruptive to the bill. And I think the industry as a whole will get used to it and can certainly operate. And I think that's important because ambulatory surgery centers in the community provide great care at a much lower cost. So we're pleased to see a bill that doesn't disrupt the industry and hopefully the centers coming online.
Okay. Any questions for Ms. Joyner?
Thank you.
Thank you very much for dispelling that inaccurate rumor that seemed to have been floating around all during the debates. Thank you. Dr. Chapman.
Madam Chair, members of the committee, thank you for giving me the opportunity to appear before you this afternoon. I'm Jack Chapman. I am president of the Medical Association of Georgia, private practicing ophthalmologist. I'm also here representing the Georgia Orthopedic Society. I'd like to begin by thanking those that have put together this substitute for Senate Bill 433 for their efforts and hard work. Although the Medical Association of Georgia does not believe this is a perfect bill, we do believe that it is a reasonable compromise that will ultimately make high-quality, cost-effective care in a safe and convenient environment more accessible to the citizens of Georgia. As such, the Medical Association of Georgia supports LC 332591S as a substitute to Senate Bill 433. If I may, I'd like to make a few brief points about the bill. Yesterday, there was some concern with consistency in the bill, particularly in regards to the indigent care commitments. There are a number of reasons for the commitments, and the exempt ASCs should be different. The indigent commitments are a percentage of the facility's adjusted gross revenues. They're a percentage of the adjusted gross revenues. Because Medicare reimburses ASCs at 65% of what they pay hospital outpatient departments, and reimbursed by many other payers is tied to Medicare, the ASCs would have to do many more patients, indigent patients, to satisfy the commitment. So if you have one here and 65%, it doesn't take much to figure out you got to jump more hoops to get up to the level. So that's why it makes sense for the level to be lower. And given that hospitals in major metropolitan areas of our state fall short of their commitment, despite providing services across the spectrum of specialties, giving them a greater patient mix to draw from and satisfying the commitment, it simply wouldn't be realistic to expect a single specialty ASC to satisfy the same percentages, particularly in light of the differences in reimbursement. And additionally, hospitals receive significant financial support in the form of state and federal tax exemptions and subsidies for providing the care to the indigent patients. Physicians receive no such financial support. The indigent care provided by physicians is truly uncompensated. This is despite the fact that the indigent care provided in hospitals is in fact provided by the doctors. For these reasons, we believe differences in indigent care commitments are justified. MAG's position has long been that an indigent commitment would be appropriate and acceptable provided the financial threshold for CON exempt ASCs was eliminated and physicians receive some form of credit for the indigent care they provide, the truly uncompensated care, and also that they provide in hospitals. Although this bill only increases the thresholds and does not provide credit for indigent care provided by physicians in hospital setting, we believe that as a total package, it strikes the appropriate balance. As for the existing ASCs currently operating, although they certainly would have preferred that they be completely grandfathered and not subject to the indigent commitments at all, the approach in this substitute, which triggers the commitments if an existing facility expands or relocates, is a reasonable compromise. Regarding imaging and the requirement that all freestanding imaging centers obtain a CON regardless of cost, we understand the reasoning of the authors. That is to prevent the use of cheap and old equipment to avoid exceeding the threshold and being subject to CON. While we believe the preferable, more market-based approach would be to eliminate the threshold, we understand this is a compromise, and we appreciate the provision that keeps physicians' offices and hospitals subject to the threshold for imaging equipment. As this bill defines single specialty, we certainly support the inclusion wholeheartedly of general surgery as a single specialty. We believe this change is long overdue and will bring Georgia in line with the other states in making it more attractive to general surgeons, which are a necessary component, as you know, of a viable trauma system, which we know how important that is. In conclusion, we believe this substitute to SB 433 will lead to greater cost savings in health care, increased patient choice, and greater access to high-quality care in a convenient environment, and we ask for your favorable consideration. Thank you. I appreciate you allowing me to be here, and if you have any questions, I'd certainly be happy to try to answer them.
Okay. Thank you, Dr. Chapman. Are there questions from anyone? And Dr. Chapman, do any, in justifying the differences in the commitment level, do any of the ASCs receive tax-exempt status?
No, ma'am.
In any form, on anything they buy or on their land or anything?
No, ma'am.
So the ones owned by the physicians and all do not receive any kind of tax-exempt status?
No,
like
ma'am.
our hospitals, our not-for-profit hospitals? Okay.
Yes, ma'am.
Thank you very much.
Thank you.
Mr. Riker.
Good afternoon. My name is Leo Reichert. I'm here today on behalf of the Georgia Alliance of Community Hospitals. We, too, appreciate the efforts of everyone to try and resolve this issue. We have been involved in it, as Representative Scott said, for the last 4 years in trying to improve the system, to streamline the system, and to make it better. Unfortunately, we do not believe that this substitute offers the appropriate balance that protects our hospitals, our not-for-profit hospitals, and so the Alliance is here today in opposition to the substitute. I won't repeat some of the things that Ms. Sellers mentioned about concerns on the bill. We share those concerns. We share the financial concerns. Given the time that we have, I want to address a few specifics. First, the single specialty exemption, which is, of course, no longer going to be a single specialty exemption. It's going to be broadened to allow some multi-specialty. The cost threshold will be raised overnight by almost 50% from $1.7 million to $2.5 million. The net result of this is going to be the loss of insured patients from hospitals. That is the only thing that can happen from the new general surgery centers and from new, larger centers that are physician-owned. So we are very concerned about the single specialty exemption, the way that it's incorporated into the statute. We are also significantly concerned about the CTCA provisions. Now, you've heard about the CON Commission, and we went through a 2-year process, and I just want to be clear that CTCA did not come before the CON Commission. And the other thing that I'd like to be clear about is that CTCA has never applied for Certificate of Need in Georgia. What they seek, if you read the provisions of this bill carefully, is not the opportunity to apply in Georgia under rules that would take into consideration the fact that they say most of their patients would come from out of state. What they seek is effectively a guarantee that if they come in and file an application, the department will stamp yes on it and they can build. Respectfully, we don't believe that there is a justification to give this out-of-state company any benefit under the CON laws that's not available to Georgia's hospitals. Now, you heard last year we talked briefly, I think, about a Washington state. There was an initial decision in Washington to deny CTCA the opportunity to build a hospital in Washington state where they already had an outpatient center. After the session last year, there was a decision made following a full 2-week evidentiary hearing in Washington. And I think we have shared that with you. You've had some of it on your desk, but I want to point out a number of things from that decision. One of which is that after 2 weeks of testimony, evidence from CTCA and the other hospitals in Washington, the judge there concluded that CTCA did not offer anything unique. Nothing about the cancer care that they provided was different from the quality or type of cancer care that other hospitals in Washington provided. We would say that's exactly the same here in Georgia, that if put to the test, CTCA could not prove that what it offers is unique. We also believe that put to the test, they may not be able to show that they're going to have 65% or more of their patients from out of state. And unfortunately, the way that this is worded again, and I don't have time to go through it paragraph by paragraph, we believe it's simply a guarantee rather than the opportunity to provide an application. One of the other things I wanted to point out is the CTCA model, which was at issue in Washington and should be of concern to the members of this committee. And that is, it is a model that discourages Medicaid patients, discourages Medicare patients that don't have secondary payers, and discourages indigent patients. After a 2-week hearing in Washington, the judge concluded that those hospitals are not financially accessible. The policies of CTCA expressly required that uninsured patients had to put up a deposit of $150,000 to walk in the door there. You may recall that last year we shared with you an article, a front-page article from the New York Times, about a gentleman who had the good fortune to win the New York lottery and the bad fortune to find out that he had cancer within the same week. He called Cancer Treatment Centers of America. He was insured. He was a railroad worker. They didn't take his insurance. He said, I've won $1 million in the lottery. I'm going to get $50,000 a year. Can we do it? And this is a quote from the New York Times. The person at CTCA said, well, no, but we would consider taking your lottery ticket. Now, is that what we want to bring to Georgia? If that's what they're going to do, we want an application process where everything is put on the table and you have an opportunity to consider whether this is the kind of company that we want to bring to Georgia. We have a couple of other primary concerns with the bill, one of which is this bill eliminates the need methodology from Level 1 OB. Respectfully, this will do nothing to promote access to OB services. CON is not and never has been an impediment to OB services in rural Georgia. And this bill, frankly, has an odd way of approaching it because it grants a need exception if there is an existing provider. So if there's one existing provider in a county and you want to come in with a Level 1 service, you get an exception from the need methodology. If there are no providers in the county, you don't get an exception from the need methodology in the area. So what it's doing is we're going to put a new program in the same county as an existing program that is invested in the program, that in some instances may be a Level 3 center or a Level 2 center, the backbone of our perinatal network, that relies on healthy Level 1 babies to help cross-subsidize the care that it provides, the money-losing but necessary care that it provides through its neonatal, intermediate, and intensive care beds. Again, respectfully, we think this is just absolutely bad policy for Georgia. Likewise, the deregulation of cardiac cath is bad policy for Georgia. We don't need cardiac cath on every street corner. This is one of those areas where practice makes perfect. So we respectfully believe that should remain covered by Georgia's Certificate of Need statute. I believe I'm probably about at my 5 minutes. Thank you very much again. We appreciate the efforts to put this issue behind us. The Alliance, so that you know, has been actively involved since the end of the last session in discussions to try and see if we can come up with a way to put this behind us, because the hospitals in the Alliance, like the hospitals that Mr. Lewis mentioned, there are a lot of big issues that confront doctors and hospitals and the uninsured in this state, and we want to get to those issues, and we hope that we can do that.
Okay, I think you have a question. Representative Scott.
If I could, I just want to go over your objections again. It's the single specialty exemptions where physiatry and plastic surgery, and was there another one in the bill?
I believe those are the only two that are in the bill. Okay.
The cost thresholds being raised.
Yes, sir.
Is that cost thresholds for hospitals, or is that cost thresholds for AM surge centers that you're opposed to raising?
I was speaking about the single specialty exemption.
Okay. Are you opposed to raising the cost thresholds for the hospitals?
Which cost threshold are you addressing? The overall capital cost?
Currently, in the bill, it's at $2.5 million. It's 1.8 something right now.
As to that, I do not believe we have an objection now.
So it's okay for the hospitals, but not for the ambulatory surgery centers?
Wait, I personally think...
That's a different issue, actually.
Right, but I personally think the hospitals...
And Representative Cooper, we didn't ask for that, and would be happy to have it kept at what it is.
All right, then your objection is at CTCA, the Level 1 OB, which as I understand it, would affect 3 areas in the state. I believe it affects 3 areas in the state.
I'm not certain if it's limited to those 3 or not. I know that definitely affects 3 areas.
But the cardiac cath exemption, that is a hospital-only exemption. We're not exempting surgery centers. That's only allowing hospitals to do cardiac cath, and it's only allowing hospitals to do diagnostic cardiac cath without going through the CON process. And I guess my question would be, we have states that don't even have CON laws in this country.
We have a few that don't have any CON laws. Again, most of them have CON or some specific licensure that would require some, particularly in the Cath area. This is an area where practice does make perfect, and dispersion is not necessarily going to help us increase the quality of care.
I would agree with you on that with therapeutic, and we've maintained it for therapeutic. I mean, the bottom line is your 5 objections: single specialty, raising the cost threshold, CTCA, level 1 OB, and cardiac cath.
Well, I wouldn't say that those are the only 5 things. I was told I had 5 minutes to talk, and so I'd be more than happy to go through the bill in detail. Those are the most significant issues, Representative Scott.
All right, thank you.
Representative Peake.
Thank you, Madam Chair. Mr. Could you just help me a little bit? The Alliance of Community Hospitals, I'm just trying to understand the difference between who you guys represent versus Mr. Lewis and the 55 rural hospitals. Do you guys not speak for and represent the rural hospitals?
We represent a number of rural hospitals. I'm not certain whether there's any overlap in our membership now or not, but we represent 65 to 70 nonprofits throughout the state, big and small, urban and some rural, yes.
Okay. And what percentage of that would be of the hospitals in this state? You represent 65 to 70% of all the hospitals?
65 to 70 hospitals. I'm not sure. I'm not certain what the number of hospitals is in the state.
Our membership is 172.
Okay. GHA, I believe, represents almost everyone in the state, and this Temple said it's 170.
Okay. Okay. Good.
Thank you. Okay. Thank you.
Thank you very much.
Mr. Hartman.
Thank you. As counsel for Southeast Georgia Health System, which is a hospital down in Glenn and Camden, McIntosh County, I want to express our gratitude for the work that was done with the Destination Cancer Center legislation and the amendment to the proposed legislation that addresses unique concerns to our hospital. So I wanted to just say thank you for that, and we appreciate your work on the amended Destination Cancer Center legislation. Thank you.
Can I ask a couple of questions? Sure. The legislation that we have before us as a whole, do you believe that it is a balanced compromise? The legislation as a whole.
I don't know that I have enough knowledge of the whole of the entire legislation, the history. We certainly believe a compromise, as the GHA and the Alliance has mentioned, that a compromise makes sense. That seems like a good step in the right direction.
But you're in favor of this legislation?
I don't have an opinion as to the amended bill and haven't reviewed it in its entirety. I'm speaking just to the Destination Cancer Center amendments and what's been done for our particular concerns for our hospital.
Okay. Thank you.
Thank you.
Okay, Representative Carter.
Sir.
Mr. Hartman.
I'm sorry, I'm a little bit lost. And
okay.
You said you were with Glenn and McIntosh County?
Southeast Georgia Health System, which is in Glenn, McIntosh, Camden County, Brantley County.
I'm familiar with, but what does that got to do with Destination Cancer Hospital?
We wanted to be sure that if the Destination Cancer Center Hospital was coming, that it was in Atlanta and not in South Georgia.
Not in your back door, huh?
Well, our hospital is uniquely situated on the border with Florida and has just made a $15 million investment in cancer center. And so we think that the requirement for the population to be from outside of the state of Georgia, it uniquely affects Southeast Georgia Health System as opposed to other hospitals in the state.
Okay. I feel like I was set up for that.
Thank you very much.
All right, thank you.
For your honesty.
Chair, I would remind the members of the committee we are making public policy for the state of Georgia and not just for certain areas.
Well, Cath.
The gentleman probably thinks that is good policy for the state.
Kathy Browning.
Thank you, Madam Chair and members of the committee. I'm Kathy Browning with the Georgia Society of General Surgeons. I just want to echo what's been said here today, and won't take a lot of your time, but as general surgeons and representative for them, we want to thank you for all the work that's been put into this compromise. Like others, there are certain things about it that are harder for us to swallow than others, but on the whole, we are very pleased and are happy to support this compromise.
Okay, any questions for Ms. Browning? Okay, thank you very much. Senator, before I let Josh sum up, is there anything you would like to? Okay.
I feel like I need to respond to some of the statements made about CTCA, particularly in regards to the statements that were made regarding the facility in Washington and the credence that's given to an administrative law judge. I've seen a lot of opinions by an administrative law judge that frankly were just outright wrong, and to use that against this company is petty, to say the least. I visited this company, as many of you have, and the best evidence if they're unique is to talk to the patients who've been there. And I've talked to tens of patients. In fact, while I was out there, I ran into 2 Georgia patients that had cancer, had gone to Georgia hospitals and had been told that we've done all we can do for you. One traveled in a travel trailer all the way out there and was treated for cancer and had been living about 6 months longer than he thought he was going to live. Now, he traveled in a travel trailer out there with his wife. They've got a place for folks like that to park travel trailers. And got treatment, was very happy, and was not a wealthy person. And to describe the New York Times article as being fact, folks, you don't believe everything you read in the newspaper, I hope, especially the one here in Atlanta. But, the real issue, folks, when it comes to CTCA is there's a group of hospitals that don't want any competition. And it is as simple as that. And these hospitals are very powerful. One does not even see the 3% maximum of indigents nor Medicaid. And yet they're a nonprofit. And this company is wanting to come here and saying, we want to spend $150 million of our own money. We're not asking for the state to contribute anything in the way of economic development. We're going to pay taxes. We're going to pay taxes on everything we do. And we're going to see 3% of Medicaid and indigents. And if we don't, we'll pay $1 million the first year, $2 million the second year, $3 million the third year, and $4 million the fourth year. We're committed to see these folks that you're not even seeing, but you don't want us here. Now let me just tell you what a lot of this is about from the previous speaker. The more confusing CON is, the more lawsuits that can be filed. And the lower you keep the numbers, the more difficult it is to qualify. Now, he did say that he wants to limit the AmSurg centers, but he's not necessarily for limiting hospitals. I have worked in good faith all the way through this process. I put together a committee of people who were for the hospital, some were for the doctors, your majority leader, and we all sat down without lawyers and lobbyists and came up with what we think is a good plan. We've even limited, as one of the speakers said, CTCA to 50 miles from the Atlanta airport, which is where they want to be. And we limited them to one facility, and we're closing the door after they get here. Now, mind you, if MD Anderson, who's got a great reputation down there in Texas, wants to come to Georgia, they can't come. The reason CTCA hasn't applied for a CON before now is they couldn't. Now, DCH folks are here, and they'll tell you that. And if DCH says you can't apply, you assume you can't apply. Listen, if they were could apply, I wouldn't be introducing this bill. I'd just say apply. They tried to buy hospitals, but for various reasons couldn't make the deal work out. But I'll say this. The alliance has never been genuine about negotiating, but even today, I'm willing to try to negotiate with them. But don't come up here lying to the committee about, well, I'm sorry, Madam Chairman.
It's a passionate issue.
It is a passionate issue, but you got to tell the truth.
That's right.
And so I'm asking you to consider the bill in the entirety. We've narrowed CTCA down so much that I don't know you could narrow it anymore, and they come. But you can't tell a company there's absolutely no way you can come to Georgia. That's not what Georgia's about, and we've got to find a way for them to make an application. And they're very unique. They don't have the same need-based requirements because their patients are coming from out of state. So Josh will address maybe some of the things that were brought up, but I would just encourage you, and as you've heard most of these people here saying today, all these stakeholders, I don't think you've heard one of them say, I like everything in this bill. What you've heard is, I like the bill, there are a few things I'd like different. And you've even heard the Georgia Hospital Association that has a very diverse group, from their alliance members to Jimmy Lewis with his struggling hospitals in South Georgia. And Jimmy's right. We need to get done with this and get on to how we're going to fund trauma. And I'll be just as committed to funding trauma, which these hospitals that are opposing this bill need. But we can't do it until we get beyond this, and I'm hoping that this is the method for getting that done.
Senator, you have a couple of questions. Representative Houston?
Well, mine's not a question. I understand how passionate you feel about this, but I felt just as passionate about those doctors that came and testified in front of us from Columbus, Georgia, from the Houston Clinic, that wanted to add additional beds, additional hospital, and we wouldn't allow them. And they'd been taxpayers of this state for years, and we're going to have to go to Alabama, and I think eventually they went to it. I mean, here we denied citizens this state who'd been taxpayers, and I probably have a feeling, how can we deny these men from Columbus this opportunity and give it to somebody? It just doesn't seem fair.
Representative Houston, I agree. I agree with you. We should have never let those folks go to Alabama.
I just thought I'd make that statement.
If I had my way, I would say make everybody do some indigent work and Medicaid, and then do away with all the requirements after that. That kept them out, that keeps CTCA out, that keeps. And one thing he did say that I think we ought to look at, one thing that Mr. Riker said we should look at, if a county doesn't have OB, we ought to let them have one. If you don't have anybody delivering babies in that county, we ought to find a way to get somebody there. And make them exempt if you want to. I'm for exempting most everything, but we're not there. I'll yield to
Representative Jackson.
Thank you, Madam Chair. Senator, thank you for joining us. I have a couple of questions, Chairman. Senator, and thank you, and be patient with me because I'm kind of new here. I understand CTCA do not accept children. Am I correct, sir?
They do not.
So they're not involved in the peach care. So peach care won't apply to them.
Right.
Okay.
But they will have to do 3% Medicaid.
Now, and that's another question, and I'm pose the same question to you as I proposed to Josh, if I may, sir.
Yes, sir.
They will provide 3% Medicaid and 3% indigent care?
Yes.
So they will. So that's 6% of the people. 6% of their population would be composed of Medicaid and peach care. Is that my understanding?
Exactly.
Thank
Or they will pay the difference into the indigent fund.
Okay. If I may,
Now,
sir.
now, mind you, they don't have any tax breaks. They're not nonprofit. They pay in taxes on the property, on the equipment, etc.
If I may, sir, another question, please. So what you're saying is they're going to limit the amount of Medicaid patients they will see?
No, they can do more than that. They have to do at least that.
Okay. All right. But will they limit the amount of Medicaid patients they will see? You're saying they can? Will they limit? Will they say if when 3% of Medicaid patients walk through the door and the next patient walks and said, no more, we've maxed out our obligation for this year?
What we're doing, as we do with every hospital, is require a minimum. And this minimum is 3% of Medicaid. And I don't know that you can set the threshold higher than you set it for a nonprofit hospital that you're giving all the tax breaks to. And frankly, there's a whole lot more to that story that I won't go into today. But at any rate, we're requiring them to do what we require hospitals to do.
Senator, if I could,
Yes.
Dr. Jackson, one of the things that would limit perhaps the number of patients they could take is that we are requiring them under threat of fine to carry at least 65% from out of state. So they're going to be working hard to make sure that they reach that 65% or go above it of out of state patients.
Okay.
So they would have to balance what they take of our patients to make sure that they meet the other law or the other requirement that we are going to impose on them if the bill passes.
Representative Mitchell, currently...
No, sir. No, sir.
I'm sorry.
Jackson.
You don't have a sign up there.
I'm sorry. He's a new member.
Action.
Currently, in their current facilities, they're doing 4.7% indigent.
Okay. Okay, good.
There are other questions?
I have a quick.
Yes.
Madam Chair, what organization will monitor what percentage of patients hospitals see?
That would be DCH.
Thank you very much, ma'am.
Monitor that. Okay. Thank you. Josh, just a minute, Josh. Before you go, some other people have. Wait a minute. Oh, I'm sorry. Representative Carter. Do you have a question?
For
the Senator.
For Senator Williams, if I could, just wanted to follow up. Now, Madam Chair, I missed earlier, but it is defined in this bill that they will see 3%. It is within this bill.
You might have come in a little.
I did.
But you had a question yesterday that we are clearing up with an amendment. But that is right.
One thing I wanted to mention to you, Mr. Leader, also, I don't know if you're aware of it or not, but I understand we had a bill before Health and Human Services about the problem you spoke of earlier. Some hospitals are not meeting that 3% threshold, and some aren't doing hardly any at all with indigent care. And I believe there is a bill being introduced in the House for a study committee to study just that. So
we need to determine what the definition is, how you can apply those costs to your obligation. You know, currently the hospitals are charging a cost, not what they would be reimbursed by from an insurance company against their 3%.
Right. I thank you for understanding that.
We need to look into that.
I think that was...
We are.
I think if you'll remember, Representative Carter, that the bill that we passed out of this committee had a level playing ground on how we put in a definition what could be charged, and that is not in this bill at this time to be considered at a later date. But we had said that, and defined how hospitals could charge that, and they opposed it, and it is not in this bill, but for further discussion. We've had some people come in late just to make sure that anybody that wants to speak has the opportunity to speak. Is there anybody that came in late and did not have an opportunity to sign up on the sign-in sheet that would like to speak? Huh? Oh.
I had one question I want to ask Josh.
Well, he's fixed. I'm going to let him go. Okay. I don't see anybody. Okay, so if you can sum that up for us.
Madam Chair, members of the committee, thanks for the opportunity. I rise today, I get to wear both pins on behalf of Governor Perdue and express the support of the governor in this bill. When you've seen me sitting in that chair, I've tried not to advocate as much as just be as objective as I can and say this is the provision in the bill, this is the intent behind it, and this is the policy choice. Today I'm actually going to speak on behalf of the bill in much more of an advocacy role. But first I want to thank the members of the committee. My understanding is this committee met last year more than any committee during any session in the history of recording the time in the General Assembly. Perhaps for the committee. I can tell you not for me. As someone who first worked for the General Assembly as the counsel to the House Judiciary Committee, I have to say you have judiciary beat, and that is impressive in terms of hours of time spent on bills. But I do want to say, after this committee passed out House Bill 568, and after the session ended without comprehensive CON reform, the Office of the Governor, in communications with members of the legislature, called together folks from the hospital community, from the physician community, and we tried to come up with a compromise that we could then present to the legislature and say, we've got a deal. It's all worked out. Here it is. We literally started in the spring, and we didn't finish from the governor's office until February. And we did, on numerous occasions, get very, very close. And I want to say that during that time, both sides, the physician side and the hospital side, did move significantly from their original positions. Both sides compromised on a lot of issues. You'll see a couple of those issues in this bill. And for the folks that met that tried to put together this bill, it was after having the benefit of spending all those times with the providers across the board that went into a lot of the consensus items in the bill. And really, as has been said, for the folks in that room, if there was not agreement, it was not in the bill. And it has a broad range of support. But I do want to hit on a couple things in terms of what you heard today from folks, and even this time from members of the hospital community, that this bill has the right blend of compromise, and that's what I think it does. But even more importantly, I want to ask you to look at who testified today, but also who did not testify today in opposition of this bill. Many of you last year received the Save Georgia Healthcare pamphlet from the Coalition to Save Georgia Healthcare that had several members, and I'll just read from the group. Georgia Hospital Association, Georgia Alliance of Community Hospitals, Hometown Health, HCA Healthcare, and Tenet Healthcare. Hometown Health today spoke in favor of the bill. So to say that there is a broad coalition of hospitals opposed to this bill, I think can no longer be said. Also, you'll notice that no one came to you and spoke on behalf of the coalition to Save Georgia Healthcare, as was the case last year. And the reason is because there is not unanimity within the hospital community. As members of the committee may be aware, when we talk about the capital expenditure threshold as it applies to hospitals, there are some members of the hospital community that don't like the $2.5 million because they think it should be at least $5 million. There's not the consensus or the unity within the hospital community that there was at the last time that this bill was before the committee, and I think that is reflective of how much this bill is in fact a compromise between all sides, and likely the best compromise that is going to be made available. I will speak on two issues that were brought up, I guess three, that were said in opposition. The first is the Level 1 OB. The CON Commission was one vote away from having this be a virtually unanimous decision. It was a 4-1-5 vote. Only one person dissented on that issue. And what the CON Commission said is deregulate basic maternal services everywhere, not just in rural counties, not just in counties with only one health care provider, but everywhere. This bill is a compromise on that as well. It says only in those counties where you've got one provider that is providing basic maternity services can you then have no need shown for the others. Now, I will add two things. One, it was offered, well, why don't we exempt rural communities? The Office of the Governor would support that too. If we want to say rural hospitals, my understanding is they can get it now. They don't have a problem under need methodology, and we remember that from having a debate
over the summer as well. But when we're talking about in level 1 in these areas, it is not going to be a collapse of the healthcare system for 2 reasons. One, there are still significant other review criteria that an applicant for basic maternal services will have to go to, including the effect on the staff of an existing hospital. Because what you'll often hear is you've got an area where one hospital delivers babies and one hospital doesn't, and when a hospital comes in and tries to deliver babies, the only way they're going to do it is by taking the nursing staff and the physician from the existing hospitals. Well, that is now recognized as a concern in the bill before you. It is considered part of the review criteria. And so I think even that is an issue of compromise where, yes, all sides aren't going to be happy. We're not going to make them happy. But that is an area where there has been significant move from both what the CON Commission did, what this committee approved last session, and even from where we are now. On diagnostic cardiac cath, that too was, I think, 1 vote away from being unanimous, and we're talking about diagnostic cardiac cath in a hospital setting. We're also talking about a new CON review that will look at issues like quality of care that they do now by rule, thanks to what the General Assembly passed last year. But now it's going to be up front. An issue is going to be, can the person provide quality of care? If they can't, they're not going to have a CON. But beyond that, because we're exempting them from CON, the licensure requirements that now move to DCH look at quality of care issues. And if a facility cannot safely provide diagnostic cardiac cath, they will not have the opportunity to do so. And last, on specialty hospitals. It is the position of the Office of the Governor that this bill should go forward. It is also the position of the Governor, and as it was last year, the Governor is not in favor of any barrier to entry for someone to come into the state of Georgia, be they a general contractor or be they a destination cancer hospital. At the same side, he thinks parties should have to go through a process. This bill does that. But going forward, should this bill pass, the Office of the Governor is not going to be interested in initiating legislation on future specialty hospitals. Should this bill go forward, hopefully it is the last time that the General Assembly will need to look at CON for a significant period of time. In fact, the last time that the General Assembly made comprehensive CON reform, it was in 1991 or 1992, somewhere in there. So this is not something that happens all the time. And I just want to say in closing, again, this is something that could not have been done without the work and the leadership of the legislators on this issue, starting not this year, but starting last year and even before that with the CON Commission. And this bill has been vetted. These ideas have been vetted. I hope it's something y'all can support. And I hope that this is the last time that we'll have to deal with CON for some time. Thanks.
Questions for Josh? Representative Houston.
I had just two little small questions. We had someone come and testify in front of us that they had to get a certificate of need to change all the carpet in the hospital because it went over a certain amount. Are we going to clear that up so the hospitals wouldn't have to come before us to change carpet?
Yes. That would be considered a non-clinical expense, like parking lots and so on. That will be expressly exempt under the new legislation.
Okay, I just didn't want them to have to come back for carpet. The next thing, and I know, did it ever say in this on page 22, and I'm sure that the place is going near the airport in Atlanta, but there are no airports in Georgia that have more than 5 runways. You can't consider Warner Robins an airport.
I don't think so. Certainly not the intent.
I know it's not the intent of the law.
Is it? Well, we can fix that. Commercial.
Commercial. If we can put that commercial out.
Commercial international airline.
Uh-huh.
Is that the last question? Josh, can you stay? And Senator, we'll get through. After the committee's over. Huh? Oh, Representative Peake. Sorry.
Madam Chair, Josh, just to comment too. Thank you for all your work you've done. Boy, you've been the man behind this thing. So thank you, and Senator Williams as well too. Appreciate what you've done with the group over here too. I do have a quick technical question though. My colleague and I were chatting about this. I just want to verify it. We are not defining what revenues are under this thing to determine how to determine the 3% indigent care. Is that going to be done through rules and regulations through DCH, or how are we going to define that?
No, okay, go ahead.
There is already a process in place for CON-based ambulatory surgery centers to calculate the percentages, and we were going to use the same method of calculation that they currently use in calculating it.
And it defines what revenues are and...
Yes, sir.
Yes, sir.
Okay. Just want to make sure that's clear.
I thought you were talking about hospitals and stuff in the overall, but there's...
No, of how we're going to require them to do percentage of indigent care. I just want to make sure we're clear on how we're defining the revenues as well.
It is based on what the CON ambulatory surgery centers that are in existence do. There's about 50 of them or more now, and that's what they do.
Okay. Just want to make sure we're clear.
Okay. All right. Any other questions for Josh? Okay. Well, that's just Josh for that. The couple of people that we didn't hear from were the people last year who were able to sit down and work out their differences very well and quickly. Would be our nursing home and the continuing care, private continuing care. Everything okay with you guys? Like that. Thank you very much.
My understanding was that there was going to be a technical amendment to put the definition back to where it is in the code already.
Right. Okay. Other than that, everything's okay with you too. Okay. This committee will meet again in the morning at 10 o'clock in room 606. We will meet in the morning. Need to have, at in room 606.